Hey guys, um, my write-up is longer than 5 minutes, and so I'm going to abridge it for you. A discussion of informed consent is the first part of my write-up, and it's also included in my procedure note, so if you want more, you can look at the first section of what I wrote. I'll begin by talking about the discussion of the step-by-step process for placing an A-line. I basically walked through the entire procedure and told the patient pretty much exactly what's going to happen. Which is then also reiterated in the procedure note itself. But I think the important part is to really make sure the patient understands why they're having the procedure done and what to expect. And the salient points for me there are that it will be done under sterile conditions with the best attempt at avoiding infection, and that it won't be a painful procedure because it will be numbed with the lidocaine first. So done under sterility, and they won't feel it, and it will allow us to monitor their hemodynamic stability and limit the number of pokes that they'll get for blood sampling. I also go through and explain the Allen's test to them so that they know what to expect for that, and that the A-line will be sutured to their skin with a simple one suture and covered with an occlusive dressing. I also go into a little bit about how the transducer, once it's attached, needs to remain at the level of their heart so that they understand that, and that it will be removed as soon as possible. My procedure note contains an indication, date, time, location of the procedure, and who did it and who the attending provider is, the equipment used, and the CPT code. I go into details about the informed consent, which I assumed the patient was alert and oriented for, and included their spouse. Indications and benefits included, again, hemodynamic monitoring and blood sampling, risks including blood loss, hematoma formation, arterial trauma, and infection. And I discussed with them that the alternative vascular access for liver transplant is not recommended. It is recommended that they use an A-line because if we want to have, successful transplantation and inpatient recovery, we need to be able to do that arterial monitoring, and that it's more comfortable if they don't get arterial pokes all the time. And I didn't have any conflicts of interest to disclose, and the patient consented. And so the procedure summary is that collateral circulation in the right hand was verified via the Allen's test. My hands were washed. Sterile PPE, including gown, gloves, mask, and cap, were donned. Sterile probe and cable cover applied, and sterility was maintained throughout the procedure. Timeout was performed. It was one attempt, thank goodness, verified by arterial flashback, and monitoring was connected and calibrated. Waveform and blood pressure were appreciated, and patient tolerated the procedure well without complications and an estimated blood loss of 3 mils. I have a minute left. I believe that the values in our ABG interpretation represented compensated respiratory alkalosis. The pH was at the high end of normal with a low bicarb, indicating that the kidneys have responded to respiratory alkalosis by removing bicarb. Their PaCO2 remains low, and they remain hypoxic, which could be the result of hyperventilation on vent, a PE, or other obstructive lung disease. Brinkman and Sharma, 2023. Patients with long-term liver disease have also been noted to have an abnormally increased respiratory drive, which can lead to alkalosis. Golemapour et al. 2020. So I hope that's a quick summary of a fairly long write up, and I hope you guys have a good week. Thanks.